Hi, I'm Sarah Helms, and here's my name, Sarah Helms. And so we are working with case connections for today. So I'm just going to pull that up. So I decided to do case 3 and case 1. Let me just make sure I'm showing up. Okay, good. So I decided to do case 3 and case 1. So case 3 is where I'm going to start. And we're dealing with a 47-year-old man diagnosed with gout based on his lab and the presentation of pain in his right great toe. But gout can have more than one cause, and we are asking, based on his high plasma urate but a low count of urinary uric acid, what can we understand about what has actually caused his gout? Then there's an additional piece of information that the patient shares later, but for now what we know is that plasma urate is usually less than 7 milligrams per 100 milliliters, but the patient's is 10.5, so a little bit elevated. Yet his urinary uric acid is hanging at 215 milligrams in 24 hours, significantly less than the average value of 413. So I'm going to circle back and talk about what gout is, then break down what might be causing this patient's pain. So gout stems from high levels of uric acid, the final product of purine salvage, or purine degradation. I apologize, not purine salvage, purine degradation. Interestingly, other mammals can have an enzyme, uricase, which breaks uric acid down to a water-soluble product, but humans do not. Humans and I think large primates do not. So we just have methods to minimize the levels of uric acid. So enzymes in a common pathway, which includes if the purine is adenine adenosine deaminase, then a purine nucleotide phosphorylase, then finally xanthine oxidase, and all of these operate in the GI tract mucosa to break down purine deoxyribonucleotides. Then there are also purine salvage reactions that can recycle the free purine, so no longer the purine deoxyribonucleotide, but now just back to the purine itself, back into purine mononucleotides. So the purine is recombined with the activated ribose sugar, PRPP, or 5-phosphoribosyl 1-pyrophosphate, to form AMP, GMP, or IMP. So again, we don't have the non-soluble uric acid building up. And brain tissue, erythrocytes, and some leukocytes are tissues that make use of that purine salvage process. So returning to our patient, we can wonder about his gout, and is it because of overproduction of purines, because of decreased purine salvage, or is there something leading to this decreased urinary excretion of uric acid? So if it was overproduction of purines, then that could be because there's just heightened PRPP, which would often stimulate purine synthesis. That could be from heightened rates of protein catabolism. So heightened activity in PRPP synthase and PRPP production activates an enzyme called GPAT, or phosphoribosyl pyrophosphate glutamyl aminotransferase, and that's an enzyme in purine synthesis. Purine overproduction could also stem from von Guericke disease, which is a glucose 6-phosphate deficiency. And so even though that's not an enzyme directly related to purine synthesis or degradation, it can lead to increased ribose 5-phosphate, and thus increased PRPP, and thus increased purine synthesis. However, that doesn't explain the decreased urine excretion, so it's probably not just a case of purine overproduction. Or if it was decreased purine salvage can be characteristic of a rare disease, Lesch-Nyhan syndrome, and a deficiency in the hypoxanthine guanine phosphoribosyl transferase. However, this syndrome does come with some erratic behavior abnormalities, which our patient hasn't shown, and still decreased purine salvage in any form, whether it's that syndrome or something else, would still show an increased urinary production of excretion of uric acid. So it seems like we're dealing with, yes, a decreased urinary excretion of uric acid. And that suggests trouble with the renal system. And I found a 2013 paper, which is in my references, explaining that indeed hyperuricemia, elevated levels of uric acid, can often stem from underexcretion and can be linked to dysfunction in urate transporters. So the elevated uric acid isn't actually getting excreted, and that also creates an elevated uric acid level in his body, not in his urine. But that said, we need to consider one more piece of information. Our patient lets us know that he has been drinking 4 to 5 liters per day of regular soda now rather than diet soda. And we are to assume that the soda is likely sweetened by high fructose corn syrup. This is really important for understanding the patient because fructose metabolism requires ATP. When ATP is depleted, AMP actually stimulates the production of uric acid. And so then why wouldn't there be an increase in the urinary excretion of uric acid, considering that we've stimulated production of it? I was able to find that high and sustained levels of fructose metabolism create oxidative stress that can actually suppress the urate transporter. And all of this seems relatively recent, at least the research coming out about it on the past 2 to 3 years. But that is likely the case for this gentleman and the onset of his gout. It's a decreased urinary excretion, probably brought on by an overconsumption of fructose, and that creating kind of artificially high levels of AMP, but also then decreasing activity of the urate transporter in his renal system. So that's case 3. I'm just going to check where I'm at with time. 7 minutes. Okay, well, I'll try to move quickly with case 1. So case 1, we've switched to understanding the case of a newborn girl where she appeared normal, but within 24 hours showed lethargy, hypothermia, and apnea with difficulty breathing. So first we're going to think through the diagnostics. That would just help us distinguish between a urea cycle disorder and a disorder with beta oxidation. Then we will refer to her blood workup and try to hone in on specific enzymes. So we have 4 options to talk through in terms of a diagnostic that differentiates between a deficiency in beta oxidation of fatty acids or a urea cycle disorder. So blood glucose, urinary acids, serum fatty acids, and plasma glutamate. So we know in general that in disorders with the urea cycle, symptoms for most conditions are going to show heightened pneumonia. Heightened pneumonia can lead to increased glutamine synthesis as the body's tissues try to reduce toxic ammonia. With a deficiency in beta oxidation, we should see symptoms of hypoglycemia, so high glucose levels, fat accumulation, or higher rates of ketone bodies. Yes. Sorry, I'm getting a little lost in my notes here. So the first thing I thought about was that blood glucose, yes, will demonstrate hypoglycemia, but high blood glucose can also be related to a number of other pathways involving glucose metabolism, so that's just a note. Heightened urinary acids could also be related to uric acid or purine degradation. And then while serum fatty acids could point towards a problem with beta oxidation, fat accumulation can also be related to high levels of orotic acid, and orotic acid can be related to problems with the urea cycle, as we'll see in a few minutes. So that's a confounding thing. Both processes could increase levels of orotic acid, so that's not a helpful measure in that both an increase in uric acid could increase serum levels of fatty acids. Kind of the same thing with increased plasma glutamine. I said that it can increase that if we have higher levels of ammonia, that can increase glutamine synthesis. But plasma glutamine levels can also increase if beta oxidation of fatty acids is inhibited due to a decrease in acetyl-CoA formation and a decrease in tricarboxylic acid cycloactivity. So switching back to thinking about blood glucose, I'm not entirely sure about urinary acids versus blood glucose to differentiate between beta oxidation deficiency or urea cycle deficiency. But if we know that we are only dealing with beta oxidation or urea cycle deficiencies and we aren't having to question, well, might it also be something else? Since beta oxidation can lead to its own increase in urinary acids, but different urinary acids than would present with a urea cycle deficiency, I will say that's our strongest diagnostic, have specific evidence that there is one condition over the other. High blood glucose would certainly show a deficiency in the beta oxidative pathway, but it wouldn't tell us anything about what was happening at all with the urea cycle. So that's my answer there. Then when it comes to pinpointing specific enzymes involved in her condition, we need to look towards her lab results, where we saw that blood ammonia was far elevated and then continued to rise, and uric acid was very high, where citrulline levels remained normal. So our lab points towards a deficiency in either the first enzyme in the urea cycle, carbamoyl phosphate synthetase 1, or in reaction 2 of the urea cycle with ornithine transcarbamylase. The first clue is that her ammonia levels are so drastically high, and that shows that ammonia is not transferred out of her system at all or allocated to a non-toxic compound or state. And if she was making it to later reactions in the urea cycle, we would kind of at least get one of the ammonias out of the way, allocating it to citrulline. But in this case, she also has elevated uric acid levels, which means there's a deficiency in ornithine transcarbamylase. Oh my gosh, sorry, there's a really big bee that just flew over my head. I apologize for that, interrupting this video, but I am going to change location because it's crawling on the window next to me. I could pause, but this will be brief, so I am just going to move. And again, I apologize. Okay, new location. I'll make sure you can see me fine. Okay, sorry about that. And I'll block the window there. Okay, so real quick, I'm going to wrap this up. So yes, in a deficiency of ornithine transcarbamylase, excess carbamoyl phosphate increases uric acid levels because carbamoyl phosphate also stimulates pyrimidine synthesis. Since carbamoyl phosphate is still being synthesized, we know that there's not a deficiency in carbamoyl phosphate synthetase 1. Additionally, citrulline levels remain normal, and the urea cycle is a cycle in the sense that citrulline levels are constant, and so we aren't reaching the part of the pathway where citrulline is being synthesized and then maybe blocked and artificially increasing citrulline levels. So because we aren't reaching the later part of the urea cycle pathway, we aren't affecting the citrulline levels. So that is my understanding of cases 1 and 3. It allowed for some great review of several metabolic processes. Sorry again about the bee that found me, but thank you for watching, and I hope you enjoyed getting to hear my thoughts on that.